Today's guest is one of the true pioneers of dialysis access. Dr. Gerald Beathard started performing the first interventional procedures for dialysis access back in 1985, back in a day when nephrologists were not really involved with this domain. So it's a huge privilege to have you today with me, Dr. Beathard, for the Let's Talk About Access.
Well, thank you.
So let's travel back to 1985. How did you start doing these procedures? What triggered you? What was the motivation?
Well, I was in private practice at the time, and I was seeing patients with problems with the dialysis access, and I had no idea what was going on. I remember one day a young man that was on dialysis was having a lot of problems with his venous alarm going off. We're having trouble getting adequate flow. And I remember standing there looking at it and just wondering what the heck is going on. I just had no idea. And about that same time, there was a paper published from a group in Oregon, and they reported 5 cases of venous angioplasty. You know, the first angioplasties done in the United States were arterial, coronary, done in 1978. And so this was, like 7 years later. But this was one of the first publications of venous angioplasty. And they did 2 cases of dialysis access and was successful. And so I decided to start doing angiograms. And where our primary dialysis unit was in the clinic was right across the hall was radiology. And so I started taking patients who were having problems and leaving the dialysis needles in place, taking them across the hall and just doing a single shot film, injecting contrast and telling the radiologist, okay, shoot, and inject the contrast. Just do a one-shot angiogram. And I was seeing these stenotic lesions. And so I remember one day I had a patient and had a stenosis in the cephalic vein. And I called one of our surgeons. We had some very good surgeons at the time. I called one of our surgeons and I told him, I said, have this patient and he's having these problems, and described the problems. And I told him I've done an x-ray and I see this stenotic lesion. And he said, well, send him to my office. I'll make an appointment and I'll see him. I said, well, do you want me to send the film over? He said, no, I don't need to see the film. And what he did is he created a new access. And about that same time, we were multi-internal medicine specialty clinic. We had a cardiologist join our group that was one of the first cardiologists in the city where we live, which was Austin, Texas, to do coronary angiography and angioplasty. And I talked to him and asked him, would he do some of these cases? And he said that he would. He did 2 or 3 cases and they seemed to get a good result. But then he said, I'm too busy. I can't do them anymore. We had another cardiologist join and he called me up and he said, I'm going to a meeting in California on doing angioplasty for peripheral artery disease. You want to go with me? And I said, sure. So I went and we were there for one day. And at the end of the day, we got a certificate that said we were qualified to do angioplasty for peripheral artery disease. We had not done a single case. We just attended the meeting. So I came back and went to the hospital credentials committee and said, I wanted to start doing angioplasty on dialysis access. And they said I could do it with a proctor. And so this cardiologist that I'd gone to the meeting with said he would be my proctor. He attended the first case, was there for about 5 minutes and left. That's the last time I ever saw him. But the technicians that were working there in interventional radiology were very good. And they told me how the radiologists were doing angioplasties, and I started doing angioplasties. And I was doing them. I was working full time in the clinic. So I do them before work, after work, during my lunch break, and this sort of thing. And the case numbers began to grow. And then I attended a meeting in Florida, for some radiologists who were doing thrombectomies on dialysis. Actually, you probably know Scott Teratola. Scott was a resident at that time. He was there, and so I saw how they were doing them, and I came back and I would go over to the hospital and look on the surgical schedule and see if a patient was scheduled to have a surgical thrombectomy. And if they were, I'd call the surgeon. I said, do you mind if I do it? They never said no. And so I started doing the thrombectomies. And so that's how I got started. And at about that same time, I got a letter from Medicare, which is our primary insurance coverage for dialysis patients in the United States. And and it implied that they were not going to pay for these procedures. So I called a nephrologist that was the representative from our nephrology group. He called me back 2 days later, and he said, I talked to 3 nephrologists, 2 surgeons, and a radiologist, and all of them said that they had never heard of this being done before, and they were very skeptical as to its value. And I said, well, they're completely wrong. It's very valuable. It gives excellent results. He said, well, you need to publish it. And so I put my data together and published the first paper, and that's the way it all got started. Following that, I began to get contacts from nephrologists around the United States and some from outside the United States wanting to come to train. And so I started training people to do it at that time, and it continued to grow from there.
So, Dr. Beathard, if I understand correctly, initially was you trying to understand what's wrong with the fistula, basically?
Yes.
Why the fistula is not working well, why it's too pulsatile, why you have so important venous pressures, etc.
Yeah.
And for cardiologists and radiologists, was it something doing balloon angioplasties for coronaries or peripheral? Was it something that was being done regularly?
Well, coronary angioplasty was being done regularly. Yes. It was just getting started, really, because like I said, the first case in the United States was done in 1978. And so cardiologists prior to that time were not doing angioplasties. And so in 78, this got started and then it gradually grew. And so, like I say, this is about 1984, something like that. The first cardiologist to do angioplasty came to the city where I was, which was Austin, Texas, which is a large city with a large population, was the first cardiologist to do angioplasty. And so that's, and like I say, that paper was published in about the same time of doing venous angioplasty, which was the first report. And then I think that same group published another paper where they did about, I can't remember the exact number, 10 or 15 cases. And I think, and reported success.
And so at the time, basically, there was not even competition for these things. It was like a new field that people were just discovering, and you were discovering it for AV access and for the nephrological aspects of it. Yeah.
Yes.
How easy was it to find endovascular material? Guide wires, balloons, catheters.
It was. Do you mean the supply items? That was not a problem at the time. Although when we first started doing, we did not use the sheath. Actually, what I would do is put a dialysis needle in the access for doing the angiogram, and then do a second cannulation and go directly with the angioplasty balloon. Put the wire in and go with the angioplasty balloon directly, and then later. And I don't know whether sheaths were available at that time. I'm not sure. I'm not sure what point we started using sheaths, but the method we were using kind of evolved over time. When we first started doing them, we would identify a lesion and infiltrate around that lesion with xylocaine for deadening, and then later we started using a systemic moderate sedation to do them. So that kind of evolved. We had a lot of feedback from primarily from radiologists who were objecting to the idea that a nephrologist was doing these kinds of procedures using fluoroscopy and angioplasty. And as years have gone by, we've had turf issues with surgical groups as they begin to do these cases.
So do you think that the way that an interventional nephrologist is doing a case as compared to an interventional radiologist or a vascular surgeon, their approach is different?
No, they're not. And today, we have several societies that have meetings, and there's a commonality there in the approach. We started our national society that's called the American Society of Diagnostic and Interventional Nephrology started in 2000. And the first 2 or 3 meetings we had, it was just nephrologists, but then a radiologist started attending and became very involved. And today, when we have our meeting, we have a significant number of surgeons, a significant number of radiologists that attend that meeting as well. And so what has happened over time, we've kind of reached kind of a stable state where we interact with each other.
When was the specialty established, Dr. Beathard, in the U.S.?
Well, it started in 2000. Now, one of the problems that we've had is that we have a national organization that does board certification. We have not been able, and still today are not able to get them to do certification for interventional nephrology. And the reason that they give is that the numbers are not large enough for it to be economically viable. So our national society does the board certification. So the certification for interventional nephrology comes through our national society and not through the national organization that is in charge of board certifications. In Asia, in China, Korea, and Japan, nephrologists are doing these. Now, in some of these instances, just with ultrasound, they're not using fluoroscopy. So basically, they're not treating central venous lesions, but they're pretty active in doing these in those countries.
Did you also develop all the rules and guidance for clinical examination in the same period?
Baxter Medical Supply Company started a program of building centers for doing these. And I went to work full time for Baxter, and we started building access centers. And Baxter eventually sold that subsidiary to DaVita Dialysis Company. And we built, I think, 78 centers in about 22 different states. And my job was to go in and train the nephrologists there. So we would approach a practice who was interested in starting an interventional nephrology program, and I would go in, we would build the center, and I would be there for 6 to 8 weeks training the nephrologists to do these procedures. And so we built a total of 78 centers. And about 5 years ago, or maybe longer, somewhere along in there, I wrote a paper reporting the results of all of our cases. Over the period of time that I was there, we did 600,000 cases.
And was it initially during dysfunctional fistulas for draining problems, and later on you also realized that you can also assist maturation with balloon dilatation? Was it something that came along in the process?
Yes. When we first started doing these, we were just doing basically venous outflow problems. And later, it became obvious that some of the problem was we're doing maturation things, junction anastomotic stenosis, this sort of thing. And then we began to actually do arterial dilatations, feeding artery stenosis, that sort of thing. And I have to say that, I often kind of compare what happened with me and interventional nephrology like a relay race. I started off, but other people picked up the baton and continued on. And so a lot of the developments that we have today were done by other people. And I often have pointed out, which is, I think, completely true, that I would go in and train a nephrologist to do these procedures, go at them 6 months later or a year later, and find that they weren't doing it exactly the way I did it. And I liked the way they were doing it better than the way I did it. So I learned from them. So there's a lot of interaction back and forth over time, and it was really kind of nice to see how things were happening. It didn't stay static. It's developed over time, and I think the way I do things today are quite a bit different from the way I did things when I first started. And I've learned that from other people and continue to learn. I tell people, you never outgrow your need for mentors, and I think it's a very true statement.
So let's say, in terms of doing a thrombectomy of a fistula, like 40 years ago or 30 years ago, and doing a thrombectomy of a fistula today, given that we have much more, option and technical things and material, would you do the same things back then and now?
No. When I first started, the first thrombectomies we did was, there was a company with something called a pulse spray catheter. I don't know whether you're familiar with that or not. This was a catheter that had slits in it. And it was about probably close to 30 to 40 centimeters in length. And you put it into the access, and then you could occlude the tip and pulse thrombectomy, TPA, in through it. And because of the pressure, the slits would open, and it would kind of put out a spray throughout the entire access. And so I started doing that. And then I got to wondering, I wonder if that TPA was really doing anything. So I just started using saline by itself. It worked just as well. And then from that, I just started using a Fogarty catheter. And what I was doing initially is I was just embolizing all the clot that was in it. And of course, if it was a large access with big aneurysms that had a big clot load, we didn't do those. We sent those to surgery. So if just a regular fistula, I just did it with a Fogarty catheter and embolized the thrombus. And I wondered, well, what is that doing to the lung? And so I did a study where I did an angiogram with a lung scan before the thrombectomy, and then I did a lung scan after the thrombectomy, and I did one 30 days later. And the radiologist who read that told me, he said, well, if I had not seen the lung scan before the thrombectomy, I would have called this totally normal, the one after the thrombectomy. But by comparing the two, I could see some small areas, but 30 days were gone. And then after we did that for a while, I had someone that I actually trained that was aspirating the clot as they were doing the thrombectomy. And I said, well, that sounds good. We'll do that. And so we started aspirating the clot as we were doing the thrombectomy with the Fogarty catheter. And Scott Terratola wrote a paper where he went to surgery and retrieved the clot that the surgeon was getting from thrombectomies, and the average thrombus load from a thrombectomy on a graft was 3.8 cc's of clot. So it's not much clot.
Yeah.
And of course, in our centers, we never had we never used the thrombectomy aspiration catheters, the device, really primarily because of the cost. We only did it mechanically, and I still do it mechanically.
So it would be like a big catheter and aspiration with a big syringe.
No, what we do is just use a Fogarty catheter. So we had a sheath in at the venous end and the arterial end, put the Fogarty in the arterial end, go across the anastomosis with the Fogarty catheter, inflate the balloon, and then as we were pulling the Fogarty catheter back, we would aspirate from the arterial sheath as we were pulling the Fogarty catheter back towards the arterial sheath. And then there was a device came available, a Terratola thrombectomy device. And so after we did the thrombectomy, we saw that there were still clot fragments around. We would use what we called a thrombectomy device to go in and remove those. And we started doing it. Patients who had, if they didn't have big aneurysms, we would use that thrombectomy device in those. But if they had really, a mega fistula that was full of clot with big aneurysms, we sent those to surgery.
So after all these years and having tested almost everything for not a big aneurysmal fistula, like a regular fistula or a graft, what would be your preferred way to do the case?
Well, first thing we do is cannulate our venous site and go up with a vascular catheter, check the central veins, give our heparin, give our sedation. We try to avoid starting an IV in these patients. I'll tell you a story about that in a moment. But and then do a pullback angiogram down to the access, but not into the access. And then do the arterial cannulation. Once we did the arterial cannulation, go in with a Fogarty catheter, go across the arterial anastomosis, inflate the balloon, pull the balloon back as we're aspirating, and do that 2 or 3 times till we get a good pulse within the access. And then once that was done and successfully done, do just a very brief pulse angiogram to see if we had flow. If we had flow, then we'd take a vascular catheter, go into the arterial access, arterial sheath, across the arterial anastomosis into the artery, and do an angiogram to see if there's anything else that we need to do. Check the arterial anastomosis, check for residual clot, and that sort of thing. Once we did all that, then we're through.
So, and when you do this, what you call the venous sheath is more distal and the arterial sheath more proximal?
And like on a loop graft, a lot of our grafts, of course, loop grafts, both sheaths are put on the venous side of the graft. Mm-hmm. So at the apex of the loop, we cannulate, and that's the venous access. And then just below the venous anastomosis, we cannulate going retrograde. That's the arterial access. So, and we do that so that we have a straight shot at everything. So we can go around the curve easily with the Fogarty catheter, but with an angioplasty balloon, there's sometimes difficulty making all the circuits.
Dr. Beathard, do you think that because there was so much technology and knowledge developed, we may have tilted too much towards intervention and we tended to create fistulas that were not ideal or maintained fistulas for too long than instead of creating better new fistulas? And perhaps we did too many interventions?
I don't really think so. A number of people have said, and I tend to agree with them, that if you have a surgeon that doesn't have at least 10, maybe 15% failure to mature, he's not being aggressive enough.
Mm-hmm.
I think, and I'm sure you would agree with me, that you have a patient that you evaluate for a fistula and you say, yes, this patient is a good candidate for a fistula. But the fistula just doesn't develop. It's related to the biology of the situation, not the mechanics of the anatomy. It's the biology. And so I think that we're always going to have fistulas that do not mature. Now, there was one report that everybody keeps quoting, that say that 60% failure rate. That was a strange report. And I think, as far as I know, there's only one report where they had that level. I don't know what was going on there. That's kind of problematic. But I think today that the approach that we should take is totally individualized. And so many of our patients here in the United States, they appear to the hospital with end-stage renal disease, here, 80% of our patients start dialysis with a catheter, even if they've seen a nephrologist. And so I think that if you individualize, I think you're going to put in more grafts than we used to when we were trying to do the fistula first sort of thing. I think if you have a patient who needs to start dialysis immediately, and you look at them and you say that patient really, I don't think we can create a fistula that we can be sure is going to mature without having some work done on it. The best thing to do is put in a graft. If you have a patient, if you look at that patient and say, well, this patient is very frail, they have a lot of comorbidities, I think this patient's life expectancy is measured in weeks, months at the most, that the best vascular access for that patient is a tunnel catheter. You're doing palliative dialysis on that patient. So I think that we have evolved over time to a point where it's become obvious that individualization is the way to go. You have to individualize it. You can't have one algorithm that works for everybody.
Do you recommend regular flow measurements or ultrasound evaluation, or just clinical examination for monitoring the patients?
Just clinical evaluation. I think it would be great if we could do routine flow measurements, if we could do at least an annual echocardiogram on these patients. The problem is the cost. And, in the United States, of course, we have Medicare, but the patient ends up with 20% of the bill. And so many of our patients are very poor economically. And it's kind of hard to justify charging for some of these things when you look at the cost of them. We have patients that have large debts that they have difficulty dealing with. One of the things that I've become interested in the past few years is patients with high flow accesses. I think that's something that's was ignored for quite a long while. And we see patients. I've seen patients that had access blood flow of over 4,000 cc's per minute, and it's not unusual to see patients who have 1,500, 2,000 cc's of blood flow. And if you are really very careful in evaluating the patient, you find out the patient is really having congestive heart failure. And I think as nephrologists, we miss a lot of diagnoses of congestive heart failure for two reasons. One is that dialysis masks many of the signs and symptoms of heart failure because we're removing fluid. And so they don't have dependent edema, they don't have pulmonary edema, things of this sort. And so we miss that. The other thing is we see these patients so often that we kind of accept their situation is the status quo. So you got a patient that you've been taking care of for 2 years. You're seeing him once a week. And over this period of time, he's become more frail. He's become he can't walk as far as he used to. this, or, and you think, well, that's just his normal state. You've become accustomed to seeing him in that state, and you accept it. But if you really get critical and evaluating the patient, you find that the patient has a very high flow access and has developed congestive heart failure, and it's correctable. There's a paper published just recently where a group of cardiologists, a group of nephrologists were evaluating these patients for high output heart failure. And the cardiologist diagnosed over 50% of the patient population had congestive heart failure. The nephrologist diagnosed 30-something%. There was that much difference between the two. And I think that's a problem. So I think it would be great and very productive if we were able to do routine flow measurements on these patients just on a routine basis and do a cardiogram annually on these patients, because the high flow does many things. High output heart failure, pulmonary edema, it affects the efficiency of dialysis because of cardiopulmonary recirculation. So there are many things that happen. Steele syndrome related to that. It's a great problem. So I think, in answer to your question, I think it'd be great if we could do it. I think the problem is cost for us.
I totally agree with what you're saying, but I also see the opposite thing sometimes, especially here in Europe, that perhaps some things are still for free and the cost is relatively lower than the United States. I see that sometimes some colleagues are asking ultrasound or flow measurements or even a fistulogram, while a physical examination that can very precisely provide a diagnosis is not adequately performed. And sometimes we have patients with pulsatile fistulas, and nobody is raising the alarm soon enough until the patient gets a bleeding after the puncture. And it's really making me ask myself, why is not clinical examination for fistula something that is not being taught more efficiently worldwide?
Absolutely. What you say is exactly, in spite of what I just said about the flow measurements, I don't think that there's anything that happens to the dialysis access that cannot be picked up, or at least strong suspicion of, by physical examination. I think that that's 100%. The problem is, here in the United States, is that nephrologists in training are not being taught how to do an examination of the vascular access. And the reason they're not being taught how to do that is because they don't have anybody in the program that is trained to train them. So what is done recently, and I've been involved with, is the American Society of Nephrology is currently developing a program that we call Train the Trainer. And what it has two components. One is we're creating, in fact, I've written the scripts for 17 videos that are going to be produced to talk about physical examination that's going to be posted on the internet. So that, and number of these are short, like 5 minutes. So if you want to, how do you diagnose stenosis of access? 5-minute video tells you how to do it. How to recognize different types of access. Most nephrologists can't even distinguish between a brachiocephalic and a brachiobacylic fistula. So it's a trainer videos. Then the other part of this is we're creating a set of slide program, and we're going to have nephrologists go to different regions of the United States and put on a seminar to train the trainer how to do physical examination. So our goal is to try to get the nephrologist in practice able to do a physical examination of the vascular access and detect these problems early. And just as an aside, whenever I was training nephrologists to do interventional nephrology in these centers that we were building, we got to the point in some of these centers where the center had been in operation for, say, 4 or 5 years, and they had a new nephrologist that needed to be trained. I'd go in to train them. They were not having enough thrombosed accesses to train nephrologists. We had to go to South Carolina to John Ross's facility and train them how to do a thrombectomy there, because in their center where they were doing this on a systematic basis, their thrombectomies had disappeared.
Beathard, you are widely considered being kind of like the father of interventional nephrology.
Actually, today I'm the great-great-grandfather.
Yeah. Okay, so be it. And I think that, that it's great creating things, new technologies, everything, but creating literally a specialty, it's a whole different category of creativity and achievement. Looking back 30, 35, 40 years, is there anything that you would have done differently?
Well, I didn't realize what I was doing when I did it. It kind of happened. I look back and I see mistakes that I've made. And I tell people that I train, mistakes are very important. They teach you things. When you make a mistake, sit down and figure out why did you make that mistake and what can you do to keep it happening again. So I don't see anything that I don't really see anything I could have done differently. What I did was not planned. It just happened. But it's been really a tremendously enjoyable, tremendously gratifying thing that I've been involved with. And I'm just happy today that I'm still able to be involved with it. There are not many people my age that are still actively practicing, and I'm practicing half time now, and I enjoy it and enjoy the interaction and enjoy the patient contact. And so it's been a real blessing to me to be able to do what I've done.
Dr. Beathard, what do you think was the most motivating power behind everything? Was it curiosity, scientific for, the mechanism? Was it to be successful? Was it to create something new? What was the power behind everything else?
I think all of those, I was told to someone just the other day, as an internist and as a nephrologist, you see patients, say, that have hypertension. So a patient comes into your office and you say, well, your blood pressure is doing okay. It's in a good range. Your medicines are good. Let's see you again in 4 months. Well, that's kind of nice. But to have somebody come in that has a obvious problem and you do something and now it's gone is very gratifying. And I think you as a surgeon, you have a lot of experience with that. I mean, you have a patient who's got a problem, you do a procedure, now it's gone, it's over. That has to be tremendously gratifying. And I see these patients who have these problems, they're worried about them, they're anxious about them, and you do something really relatively simple, and now it's over and the patient feels better about it. You feel that sense of gratification that you actually have accomplished something. I think it's a wonderful type of thing to have.
Dr. Beathard, you're not only an amazing physician, you're truly an amazing person. And I'm very grateful that you dedicated almost 1 hour of your time to give me so much knowledge and wisdom and share it with the audience. And I hope they will be able to watch it and learn from you.
Well, thank you so much. I appreciate the opportunity.